appreciate this opportunity to present our work produced in the rat. So the talk is electroacupuncture and laser acupuncture alleviate knee arthritis pain in rat. Although acupuncture or electropuncture has been very commonly used in China and most East country for 2,000 or 3,000 years, but in the Western country, the story starting around 1970. Currently, there are 3 surveys in America about acupuncture use. 1 million people used in 1997 survey, and 8 million people used by 2002 year. This is the total people. But another survey in 08, 3 million people used in previous year. So there are more and more people use acupuncture. We do mechanism study in the animal model. We insert the needle into the acupuncture GB30. GB30 is the acupuncture localized in the line between great trochanter and the sacral hiatus on the point of the lateral 1/3 and the medial 2/3. So we induce the pain in the rat by injecting complete fluid adjuvant into the hind paw, induce peripheral inflammation. We use this model to test the different parameters of the electroacupuncture to see which kind of parameter is the most effective. And we measure the paw withdrawal latency. So if the latency becomes shorter, that means pain. Latency becomes longer, that indicates the pain inhibition. We measure the pain after the electroacupuncture treatment, 2.5, 5 hours, 1 day, 3 days, 5 at 7 days after the treatment. So this is the procedure. How do we do the electroacupuncture on rat? So it's this is the we inject into the GB30, and we fasten the needle with the tape, and we put the rat under the box. During the electroacupuncture, rat can move around in this box. It's afraid moving. And this is to show how we measure the paw withdrawal. We stimulate the point hind paw with the thermal stimulation. I think I have a small clip. When rat withdraws the paw, the machine can record the time automatically. First, we use this compare the 2 control. One is needle insert the GB30 point, but no electroacupuncture, no electro stimulation. Another control just put a needle outside the point, no electro stimulation. And another is just inject safely, no any treatment. We compare these 3 animal model and measure paw withdrawal, and we cannot see any big difference. This is ipsilateral, and this is contralateral. This is y-axis is paw withdrawal latency. The normally rat withdraw their paw around 10 seconds. When they get the information, the paw withdrawal latency becomes shorter to 5 seconds. We also test the different point. One is the real acupuncture point, GB30. That is the distant point. This is on the forepaw, the TE5, in Chinese called Wei Guan. And we also the adjacent point, opposite of the GD30. We also use the non-acupoint. This is on the abdominal. So this is the result to show how this different treatment in different point influence the paw withdrawal latency. The green one is the GB30 stimulation. It has increased the pore withdrawal latency. All others have a little bit effect. So that means different stimulation on different location produce a different effect. So the real acupuncture produces most effective effect on the pore withdrawal. That means can increase pore withdrawal. That means inhibition of the pain. We also tested different parameters. We use the frequency 2 Hz, 10 Hz, 50 Hz, and 100 Hz. We use the current 2 and 3, 1, 2, 3 milliampere. We also use the different duration of the pulse. This is the treatment duration 20 minutes and 10 minutes or 30 minutes. This is the different time point to measure pore withdrawal. We can see the 10 Hz produce the most effective. 10 Hz 3 milliampere and 20 minutes produce the most effective pain inhibition in this peripheral information pain models. So that's our conclusion. In the follow-up study with the arthritis pain model, we are going to use this 10 Hz treatment. So right now we know the knee arthritis is the patient increased in the different country, no matter it's developed country, developing country, or the undeveloped country. So this is the main prevalence. This is women. So we can see compared to different scales. So there are more women has knee arthritis compared to men. Actually, both increase along with aging. So the, in the in the United States alone, so right now there are estimated 27 million adults had the arthritis in 05, and this number will increase to 67 million people by year 2030. So because people has a long life and aging population is a big issue in all the world. So, and for the knee arthritis right now, there are no therapy or treatment can heal this, cure this disease. Mostly with treat the symptom, decrease the pain, or also another major therapy is use surgery. So there are a lot of surgery, knee replacement, also hip replacement. 10 years ago, our center running a clinical trial with the arthritis pain model, arthritis pain in human. We do the 3 groups. One is the education, another is the same control, and then is the treatment. So we can see the pain score gradually decreased and has significance on the 14 and 26. The treatment is about 13 weeks. So our lab study right now there are different knee arthritis models. So one is the mice or guinea pig. This kind of animal can develop knee arthritis just spontaneous, but it takes a long time. And some rats, some guinea pig develop fast, and some later. And also we can use the surgery model, or mouse or rat. The surgery directly damages the knee. So, and but the different model has a different symptom, such as mouse surgery. They do not show the in weight bearing difference. So we can talk about what is weight bearing. So rat surgery model do not show the thermal or mechanical hypergeria. Another model we use is the intra-articular injection of monosodium acid. This model has properly used in the lab to study the arthritis pain, because this model can produce all different kind of the pain symptom. This is a model. We can, after injecting the monosodium acetate, so the cartilage has a great degeneration, has impact. This is normal cartilage, and this is damaged cartilage. This is to show how we measure the pain in another way. So because we know the injured side will have the less body weight bearings compared to normal side, we put that in this special instrument that slightly stand on this both plate. This is the left plate and another right plate. We can measure separately both sides how much weight has been supported by left or right. This is the result. We use the male rat and the female rat. This is the body weight. So ipsilateral compared to the both ipsi at contralateral. Normally, each side, left side or right side, bearing about 50% of the body weight. But after the injection of the monosodium acetate, so the injured side, the body weight bearing decreased dramatically. So it's go from 50% go down to 30 or 26%. There are two group. This is green is the acupuncture treatment, and yellow is the control. We treatment after the injection of the monosodium. We treat the rat about once a day, 1 to 8 days, 8 treatment, and we measure body weight bearing. You can see the acupuncture group recover fast compared to the control. This is the male rat, and this is the female rat. Same thing, the acupuncture recover fast compared to the control. That means indicates the electroacupuncture treatment can increase the body weight bearing on the injured side. Indicates the injured side pain alleviated by the electroacupuncture. We know pain has a different component. One is sensory component, another is an emotion. So that means during pain, human or rodents, they have the emotion effect. So in the rat, so how do we test the pain-related emotion? We use the specific instrument. So this box has both sides has different floor. This side has the big hole, this has a small hole, and this side has the horizontal bar, and this side has a vertical bar, and has a small light outside. First, we put rat in this box. Rat will move freely during these two boxes, and then we record in the time how many rats stay this side or how many rats stay another side. Usually rats spend the equal time on both sides. And then during conditioning phase, we put rat on the one side, no treatment. We put rat on this side of 30 minutes. This is no treatment. Then we give the treatment. After treatment, we put rat to another side for another 30 minutes. Rat can only move in this side, cannot go to another side. So during this phase, the rat, we assume rat has more pain this side and have less pain this side, and the rat will associate the pain condition to the environment. So after this condition, we put rat again, so rat can move both sides, and we recording the time again. So recording how many rats stay on this side, or rat stay how many minutes stay in this side. We measure the 10 minutes. So the results show this is two group. This is the same group, green and yellow, And the purple and the cyan, this is the treatment group. We can see precondition. So both group of rats spend the same time on both box, left box or right box. But after the conditioning, the control group still spend the same time on both sides. But for the treatment group, they spend more time in the treatment-related box, spend less time on no treatment-related side. That means after treatment, rats feel better. They like the treatment-associated environment. So that means electroacupuncture somehow can alleviate pain-related emotion. Another confounder for this interpretation of the data could be electroacupuncture induce reward. So for this possible, we do the naive rat, give the same treatment or electroacupuncture treatment. So
just a comment really that obviously you're showing essentially that what you're doing effectively, if you look at the gate control theory along with neuroplasticity and mix that together, you can just see that what you're doing is distraction with acupuncture because it's providing a different signal rather than the signal coming from the OA joint. And as a consequence of that, the overall pain is reduced with that. Would you agree with that principle?
Probably.
And obviously, acupuncture's been around for 8,000 years. And what's your view on the Cochrane database, which says that there's obviously inconclusive evidence to support? Well, it's not necessarily the truth, but it's variable evidence to support acupuncture. What do you see the problems? You envisage the problems that have been in acupuncture research, and where should acupuncture research be going to make sure that it proves something that's been going on for 8,000 years?
Right now, it's a debate on. I do not know outcome, but in America, there's a big debate about the acupuncture. It's a real effect or placebo effect. So I think that was three years ago. Claudia, the German scientist group, they have the big review. They include 27 patients. They collect all the individuals clinical trial, put together, and they reanalyze the data, and to show the acupuncture treatment has a big effect, has a significant effect compared to control. In the one is arthritis, one is somehow the three symptoms. They have big significance. That's the most recently evidence-based. What called? Yeah.
Do you have that reference?
Yeah, it's easy to get. I do not have that.
Just give me the name of the reference. I'll just give me the name of the author, and I'll find it. I think it's important because the problem we have at the moment is that
with Claudia,
you have the people will look at acupuncture and say, well, is it really useful?
Yeah.
The American Orthopedic Association hasn't really recommended it.
Yeah, that's the biggest one, containing a lot of patients. So also there are other Cochrane review.
Yes.
So they show maybe they called might, so not harder evidence. So because they have less people. Yeah. So.
I mean, how do you see? What do you see the way forward in terms of making things clearer for acupuncture? Because obviously you've proved something here with your rat studies. And what's the way forward in terms of clinical studies? Do you see the way forward to try and get to the truth of what's actually going on here, on how acupuncture is working? Because clearly people still use it, get benefits from it. A certain section of the population do get benefit from it.
Yeah,
it's going over 8,000 years now, so obviously it's not 8,000 no reason.
2 or 3,000 years. So actually, I'm not familiar with the clinical side, but I only know some debates. So the debate reflect between the population and in the scientist groups. There's the two groups. So debate. So
it's probably a need. Basically, it's a need for a big study.
Yeah, need big study, but 27 people is already big, so I'm not sure.
I know. I mean, Mike might have his own ideas about that and tell me what should be done study-wise, probably better than me. But I think there's a need for a good study in this area, really.
Yeah,
just
people.
to answer some hard questions. A good prospective study.
There are many clinical trials come to the literature still right now, so more and more evidence. So.
Okay. Yeah. Thank you. Anybody else? Yes.
If you permit me, I have another interesting thing to tell regarding this acupuncture. There is one ancient system in India where I live that's called Marmakala. That's origin is China, Tibet, 8 to 10,000 years old. And in fact, the sessions were conducted recently in India where I live, and I have personally undergone a couple of sessions for osteoarthritic pain of the knee joint. I myself being the patient for it. We have no invasive procedure as what you have showed just now, laser, electrocution, nothing. Just by the thumb, pressing over certain nerve centers on the leg, the practitioner is able to control osteoarthritic pain effectively within 6 to 8 weeks of period. This session is weekly once, and no ointment used, no surgical aspect, no injection, no tablet, just by the thumb. And it has been written in the internet, if you can go through it. Marmakala is an offshoot of karate. Karate, we all know what it is. This is the medical aspect of karate, and it heals. And the origin is much before the onset of antibiotics or painkillers or oral medicines or even ointments. So I just, out of curiosity, I'm telling you, this is a totally non-invasive procedure, and it is able to control pain, similar to what we have just described. Thank you.
Okay.
We have more time because there's one speaker hasn't turned up. So I'd like to extend this discussion, and we'll still finish at 10:15, isn't it? Yeah, because I've got about 5 questions for you, so as well. But
okay, thank you. Thank you very much. And my question is the response the same for the primary and secondary osteoarthritis for the acupuncture? And the other is, for which stage of osteoarthritis is good for this acupuncture?
What is the
stage of the osteoarthritis?
Oh, stage of the arthritis.
Yeah, for early stage, does it works for late stage?
Okay.
Thank you.
Okay, thank you. About the primary or secondary, so it depends on where you stimulate the body. If you stimulate the injury side, that's called the primary. So if you induce the distal side away from the injury side, that's called secondary. Because the injury side induces some central plasticity change in the spinal cord or in the brain. So that's why, except the injury side, other part of the body can have the different sensation. So that means they become sensitive to the stimuli. About the stage in the animal, so there is one paper, they test the different change about before 15 or after 15. After day 15, they have the big nerve system change compared to before the 15. So according to this according to this change, they can define the early phase or late phase, but that's still roughly. Because in the humans, it takes a long time to develop the disease. You can say it's early phase or late phase according to the X-ray change. But in the animals, it's developed inject them day 0, the next day they will feel pain, and this develop fast. So it's hard to compare, but roughly it's early or late. We give treatment on the early phase.
It's interesting you're saying that that secondary osteoarthritis is on the contralateral side to the injury. Is that right?
Because still the ipsilateral.
Ipsilateral?
Yeah. For this model, the contralateral do not show any big change.
Yes.
Yeah. But for the other models, such as the inflammation pain model, the first model I used, if you use the thermal stimulation, it only shows ipsilateral change. But if you give the mechanical stimulation, the both sides will show the decreased threshold. So in that model, the contralateral hand paw can show secondary mechanical hypergeria.
Okay.
Yeah,
So
it's a
'cause I think
different
the
model.
definition you might be talking about is primary osteoarthritis develops just de novo, just develops with life and so on. But secondary is secondary to an injury or a fracture or a poorly healed fracture, those sorts of things. So it's different. I think we're using different definitions here. I think you're talking about the phenomenon of transfer of effects from one joint on one side to the same joint on the other side, which happens through the spinal cord, and has been shown in pain research, for many years now. Particularly coming out of
there are patients they show it's shown the mirror pain, because the condylate cells the exact same pain as the ipsilateral. For the animal model, so different model with the different modality of the measurement, they show different phenomena.
Yes.
It's very complex.
Okay. Good. I've got a few questions for you, but I will go home and put vertical stripe wallpaper in my surgery and see if we can get a condition response to that. In fact, that was one of the most interesting things in your study, is that because they're rats, we take away the so-called placebo effect, which is really a psychosocial context in which treatment occurs, and that it didn't seem to make any difference, whereas all the other things, other experiments did seem to make some difference, and where just straight physical tests and so on. So, and I was interested to see that the effect was rather delayed. I think in the mechanical allodynia effect came in at 6 and 9 days, and then you had the interactive movement effect at 6 and 21 days, and then the first one you showed was 72 hours, that's 3 days. So why do you think there's such a delay? Because the patients I see, well, I don't do acupuncture, but the studies I've read, the effect in humans can occur earlier than that. And
we select a different day for the locomotion test, because we put the rats in the open field. So if rats know with the familiar this box, they will not move a lot. So that's why we test the baseline day 6 and give the big time to make rats forget about this open box, and day 21 we put it again. So for the day 6 or the day 7, day 9, that's because our treatment is day 1 to day 8. Day 6 is still during treatment, and the day 9 is 2 days after, 1 day after treatment. So it's close the treatment. We try to capture, because we are afraid the long term after the treatment, determination of treatment, the effect will go away. So that's why we select the early time.
So do you think acupuncture is inhibiting some inflammatory response as well? Would explain why?
Yes, so
why it takes 3 days or so.
We use the peripheral inflammation pain model. We measure the hind paw thickness. So after the treatment, the inflammation decreased significantly. Yeah, because the acupuncture can activate the HPA axis to increase the more corticosteroid, glucocorticoid in human. So that's peripheral action can decrease the inflammation.
So you're thinking there's some neuroendocrine effects happening here that's changing cortisol levels, etc.
Yeah, we have another paper to measure after treatment to measure corticosteroid.
Have you shown a decrease in corticosteroid levels, or increase, or
after treatment it's increased?
It's increased, which gives you the effect, perhaps. Okay. More endorphins, yes. Yes. Yep. Yeah, at a central level. Peripheral level, yep.
Yeah, so acupuncture.
Yeah, is it? Did you test endorphins?
Yeah. Actually,
can you test them in the CSF?
acupuncture induce the central and peripheral endorphin. So, but they have the different mechanism. For the peripheral side, acupuncture can recruit more inflammation cells to release the endorphin to inhibit pain peripherally. Also, they can induce endorphin release in the spinal cord and in the brain.
One of your most interesting slides was the central effects that you could show that there was electrophysiological changes centrally and blocking activity in the nucleus accumbens.
Contact,
And cingulate, did you say cingulate gyrus as well?
Yes.
Yes. Okay.
It contains single and the primary.
Yeah.
So partly.
Okay. So I think that's pretty interesting evidence. From a clinical level, you say about the variable literature on acupuncture. I think that's been plagued by the sort of the issue of what is a sham, what is a correct sham, what is an appropriate sham. But at one level, you'd think, what's the problem? I mean, what's wrong with the placebo effect? If a fair bit of the effect is placebo, and there's some additional effect on top of that, which is of variable significance, but the patients are happy, then what's the problem? So I've just got to sing against people saying that the placebo effect is no effect. It's actually can be quite a large effect, and particularly in pain studies. Yeah.
They say placebo is meant to be like 20 to 30%, don't they, sometimes? And yet, drugs that we use in pain, such as gabapentin, pregabalin, maybe even antidepressants, they only have that effect on their own, in isolation. Yet they don't get the same amount of, prejudice, as perhaps acupuncture does. And I just wonder why that's the case. When you look at it objectively, and we look at the hard facts and hard evidence, you're thinking, well, if it's working. But it's been working for 8,000 years. And they've actually plotted these meridians on to show exactly where it works best. There must be something behind this. I know it's empirical, but there must be something there that's leading to a positive effect. What's your view, Dr. Shankar?
Nerve centers, or even the Marmakala, which I just described to you, depends on the nerve centers. It has nothing to do with external appearance of the joints. The joints are under control by the pain, centers, which, we all know the sensory centers and motor centers are there. Those autonomic nervous system, obviously, exact word I should use, controls pain very effectively, and the pressure spots on that for a estimated determined time is sufficient to control pain process. This is my personal experience because I attended 7 to 8 sessions for my own pain, and to my surprise, without using either ointment, injection, or tablet, or even a surgical procedure, I'm able to control osteoarthritic pain. It's extraordinary. And the origin is from your own country.
Mm-hmm.
That is also a type of acupuncture. It's a type of acupuncture, non-invasive, totally non-invasive. You are using electrical, you are using laser, etc., etc. We do not know anything about the outcome of it. It may be temporarily good. But here is a simple pressure point. It's an offshoot of karate, medical aspect of karate. Healing process. Karate is destructive. We all know what it is.
Mm-hmm.
You do know that martial arts did come from India. You do know that. It's not that I'm trying to be, territorial about it at all. It's about sharing. It's an Pan-Asian thing. But, martial arts did come from South Asia. At least that's come to the Commonwealth Games when they sort of gave it out anyway. Carrie, what do you think as an orthopedic surgeon? What's your view on all of this?
I don't really have much to add to what you have said. I do agree that there is a bias because even viscosupplementation studies in which they've used the control of injecting normal saline in the knees and ankles have shown about a 30 to 40% success rate up until 6 months. But yet still, viscosupplementation does not have that bias that acupuncture does. I guess part of it is that complementary medicine, on the whole, I think, in my opinion, just doesn't have as strong a literature database as traditional medicine.
Or do you mean new medicine? Because that was traditional medicine in the old days. This is new medicine. Anybody have any other ideas, please? Any thoughts? Just tell us who you are and.
I am Dr. Kapil from Nepal. In our country, also when the patients come to our OPD with complaint of severe pain in the bilateral knee joint, and at that conditions, is it helpful in the severe pain by the acupuncture only, or do you need some kind of complementary medicines, and so that it will be more effective? Is acupuncture directly act to reduce the severe pain that patient complain, or is it needed some complementary medicines to treat? Yeah.
Sorry, you're saying complementary medicines in addition to acupuncture, or complementary medicines in addition to Western medicine? What do you mean? Allopathic, yes. Yes. Mm-hmm. Yes. 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 Okay. Well, that's ideal for a trial. Obviously, we call a pragmatic trial, where you'd have the patients who get just the straight allopathic medicine, and those get allopathic medicine plus acupuncture. And I can't quote you the literature on that, but I think there'd be quite a large literature on that to look at. I think these studies with the sort of sham acupuncture of interest and benefit and usefulness, but they're not the only. You need to look at also the type of study that you're talking about in a way. What is it? What's the effect of adding acupuncture to allopathic medicine? Because that's what patients do. When the patients go to the doctor, they don't. The doctor doesn't say, "I'm going to give you a placebo treatment here today," because I've heard that's just as good as the acupuncture I'm going to use. In fact, just before I came, I saw this lovely cartoon, and which had a patient who'd left the surgery and was talking to someone and said, "Well, how did the placebo treatment go that the doctor gave you?" And he said to his friend, it was good. I paid him with Monopoly money, and which is, I don't know if you know what Monopoly is, but it's fake money. It's fake money. So they gave placebo money for the placebo treatment, but so. But I think, I think we need. There's a place for both these sham trials, sham control trials, and for pragmatic trials where you compare real life treatments A with real life treatment B, or treatment A plus B. Because that's what happens in real life. And I'm being a clinician as well as a researcher. I think it's important to study what happens in real life and not just what studies happens. I think laboratory studies are very good, and the beauty of your study is that actually it shows when you remove the sort of the human factor that there's still there's a neurophysiological effect that's occurring, and you've demonstrated that quite elegantly, I think. Yeah.
Both basic study and clinical study make a big progress in America. So
Sorry? Can you speak into the...